I'd like to welcome Dr. Luca Palombi, who is a rising star in coming in from Rome in the field of phlebology. Congratulations on your recent meeting and vein in Venice.
Thank you so much. Thank you for the kind invitation. I really appreciate and I love your job, your podcast. And thank you for the question. Yes, we are pretty happy and excited about Vein in Venice. And this year, we almost doubled the participant. We have a great discussion, great speech. So it's amazing how things are going in the symposium, and I hope we will be able to do even better next year.
I'm still hearing the buzz about the meeting, so congratulations. Dr. Palombi is a counselor of the Cura Bene Roma Association. He's the scientific director for Medicare Magazine and the co-chair of the meeting. So, can you tell us a little bit about this new technology that you've been developing, Total EVLA?
Yeah, thank you so much for the question because it's it's a new topic and not really new for someone. It's not a technique that I have invented. It's been invented by other colleagues, Michael Prüfer, but others technique with similar basic procedure called Atta technique, porcupine. So. I'm not the inventor, but I think it's a really new topic, a new technique to consider for a selected patient, and I think it's a really useful technique. So if you want, I can share with you some present slides and a presentation.
Please do.
Okay, so thank you so much. My disclosure. Well, total EVLA means basically treat not just the truncal vein with the laser, but also use the thermoablative technique to treat side branches and perforator veins during the same procedure. And of course, this is the question that I often receive by other colleagues. It is really necessary to treat collaterals. Well, the answer it's not mine, but it comes from some study and of course from the guidelines. Regarding the study, I really loved and to read this one. It's a review that basically show us comparing the two groups. One in which there was performed concomitant treatment of the collaterals during the main procedure of ablation of a truncal vein, GSV, SSV, or anterior accessory saphenous vein, and the other group in which there was a staged treatment. 15 studies have been included in this review with almost 7,000 limbs. And what was possible to observe was that the reintervention rate were significantly lower in the concomitant group, and no great difference in terms of complications. So no more complications in the concomitant group respect to the staged. So no more DVT or other major complication. And instead, it was possible to observe a lower venous clinical severity score in the concomitant group. So this review is really interesting and tell us that treating the collateral veins during the main procedure could give to our patient a better quality of life after the treatment with no adjunctive or more complication respect to the staged strategy. And if we take a look at the guidelines that we do now have, what they tell us basically is that if we have a patient with, for example, GSV trunk or SSV trunk insufficient with collateral veins in a symptomatic patient, we can decide to treat, of course, this patient with a concomitant procedure of phlebectomy or foam with class 2A level B of a recommendation. So it's not really high, but if we take a look at the chart, has the same recommendation that we can find, for example, in treating patients not with thermoablation. So if you decided to treat with MOCA or directly with foam or with glue, you have the same grade of recommendation that treat collaterals during the same procedure. So, and if we take a look at the American Venous Forum guidelines, we have a strong rate of recommendation for symptomatic patients to treat also the collaterals. So this is why. And then I also give often this answer. I do work in a public hospital in Venice, in which we have done between 2018 and 2024 more than 3,000 surgical procedures for varicose veins, most of them endovascular procedure now. But still, we have in this moment more than 1,000 patients that are awaiting for the procedure. So this means that these patients have basically 1 year to wait for the procedure. So consider that also we have a lot of these patients that are heavy worker. They most of them work in the shipyards. That in Venice is really important industry. And so most of them are symptomatic. So consider to tell this patient that I'm going to treat the main trunk, and then you will come for another evaluation. Then you will wait another year to treat the collateral. So this is really hard to accept for a patient. So this brings us the necessity to do something also for the collaterals. And so these are 3 patients that I had in my hospital, and they have a similar condition in terms of work, heavy work. And in the first one, there was recurrency with huge collaterals. The one that I want to talk about now, it's a chef that has a small restaurant, so he has to cook, but also he's the owner. And so he asked me, please help me, because I have two problems. First one, I have to cook, so I'm close to the fire. I cannot wear stockings for a long period. So foam was not for me something that I would propose to this guy. And the second thing is I have to go to work this afternoon. I cannot be at home for recover from huge phlebectomies, for example. So in this type of patient, I think that Total EVLA would be a choice. This is the case. So as you can see, there was a incompetent terminal valve at the junction with reflux in both anterior accessory saphenous vein and great saphenous vein with huge calibers, as you can see from this video. There is this is the duplex ultrasound that show us complete reflux from the junction, as you can see. And sorry for the video, it's a little bit slow, but as you can see here, there is a huge reflux, and then both anterior and great saphenous vein incompetency with a huge caliber of both. And we do know that the caliber and the diameter, it's a topic, it's an issue when we consider to treat this patient about the occlusion rate at the follow-up. What the data in this moment suggests us is thermoablative technique are in this type of caliber gives us better results in terms of occlusion rates at the follow-up. So I propose this patient for a Total EVLA procedure. As I told you, the reason why: diameter, type of reflux, the work, and the necessity to go back to work the same day. And so this is the reason, and this is the follow-up. We decided I treated this patient with laser crustectomy and occlusion with laser thermoablation of both GSV and anterior accessory saphenous vein. But also, as you can see in the slide, the collaterals were treated with the thermoablation. And this is the result only after 7 days. Of course, some bruising, and ecchymosis, but this patient had the chance to go back work the same day with no discomfort, and I'm pretty sure that at 3 months follow-up, the clinical condition and also the aesthetics will be quite better. But about the total EVLA, we have a problem in this moment. We have a lack of data, or no prospective trial about this topic. So we are surgeon and we need evidence-based medicine to confirm what we do and also to adopt a technique and also for the safety of the patient. So this is the reason why we moved and we decided to create this trial. I call this trial Totem Trial, means Total EVLA multi-center trial, because in this trial, I'm working with other two great center, high volume center. One is in Poland, led by Jan Szczepanski, the Melius Clinic in Torun. And the other one is led by Linas Velika in Kaunas, Lithuania. So the design of the study is a multi-center prospective, non-randomized, non-blind clinical trial. Every center at the phase 1 have to enroll 50 consecutive patients treated with total EVLA, and we decided to have the same device for the ablation in order to reduce as more as possible some bias. So we're using now third generation laser, 1940 nanometers with 400 microns fiber. The inclusion criteria are basically C2, C6 patients, and exclusion criteria are the one that you would not treat with laser, of course. So the endpoints, we have efficacy endpoints and safety endpoints that we are now evaluating. For the efficacy endpoints, we are looking for, of course, occlusion rate, 7 days, 1, 6, and 12 months. And of course, we also want to evaluate the energy that parameters such as power button and lead, because I think it's really important now to have a direction also about this, to understand which setting is better for this treatment. For the safety endpoints, of course, the complications, but also we want to evaluate the perception of pain during the procedure. This is another, I think, important topic that sometimes other colleagues are asking me, is it painful because you have to place more needles? And so we are now evaluating also this. And of course, the improvements on the quality of life of our patients. I can show you these are the early results that I have in my center. So take this data as initial data, of course, and only of one of the 3 centers. Of course, we have in this moment only the short follow-up. So the 1 month follow-up, 100% of occlusion rate. And regarding the power watts, we have basically 42 joule per centimeter as lead for the truncal ablation. And I remember everyone, I'm using the 1940 nanometers laser. So according to the literature, it's a value that we are used to see. Regarding the tributary ablation, the mean lead was 22. So not too much, but with a good occlusion rate at this moment. But we will see at the follow-up. Regarding the safety endpoint, and I think this is really a nice data to share. Also, if it's of course initial data, is the pain perception was really low. And I can tell you that it's quite similar to the one that we have with the other technique. In our center, we perform all the technique, of course, thermoablative technique, but also MOCA ablation, rotational, non-rotational, foam, and glue. And I can tell you that the pain perception is promising. in this trial. And regarding the complication rate, we had only one superficial vein thrombosis and a case of hyperpigmentation that I want to show you this one. But we are talking about 1 month follow-up. So, of course, there is a huge difference between the pre-op and post-op clinical condition, also regarding the presence of varicose veins. But I have to tell about this case. Regarding the quality of life that we have tasted with the revised VCSS scale, it's another good data that we are now having with this trial. So, in conclusion, in my personal opinion, Total EVLA, if well conducted, is an effective and safe technique. Early data from our trial are promising. I think that it's not, as always happen in our field, a technique that fits for all. That's my personal opinion. But it's a useful technique. So if you want to increase a tailor-made treatment for that specific patient, be able to offer also Total EVLA, I think it's really important, and probably in the future will be mandatory. And I consider also this. I think it would be really nice to consider Total EVLA for the case in which, for example, health insurance refused the cover of concomitant collateral treatment, and in the future maybe will be an alternative to the ambulatory phlebectomy. So I think it's something to consider. And for sure, we don't want to have this condition to our patients. So thank you.
Thank you so much. And thank you so much for getting the data, because that's been one of the criticisms, that we need more data to really demonstrate the safety and efficacy of these new ideas. So you went over some of the advantages. When would you not do this technique? Are there some patients whose anatomy, the proximity to the skin, the size of the vein, or tortuosity, well, exactly when can you not do the procedures, or what are some of the weaknesses of this technique?
Yeah, that's an important question, and as I told at the beginning, in my personal opinion, there is no technique that fits for all cases. So the problem, it's not the depthness of the vein or the tortuosity, because with the new laser, so with the 1940 nanometers laser, there are now data. I have done a review also about this that was published almost 2 years ago. That when the problem about the superficiality of the vein, it's less an issue with with this type of laser. We also have published last year and an evaluation with about the histology of the vein after this treatment. Basically, what you have with this new laser is that the damage during the procedure, it's limited to the medial wall, and so you don't have a damage of the adventitia, for example. And this is really important to consider the spread of the heat during the procedure. So the surrounding tissue are less involved as we had with the previous laser. So I think that the superficiality is not the issue. The tortuosity, you can consider this, of course, by placing more needles. And that's what I think. Sometimes I don't want to place 20 or 30 needles to the patient for two main reasons. When you work in a public hospital, if a procedure is time consuming, it's not good because we have a lot of patients to treat. So it is possible to consider, in these cases, not to treat with the laser, but do a good foam for the collaterals. And then other, I don't think contraindication, but sometimes there is patient with fear of needle, and so you have to consider also this when you treat the patient. So sometimes we offer MOCA for this reason, not to do too much chance or a long procedure. So I think that also over the years, with case that we have done, we have more than 500 cases also with Total EVLA. So we are getting more experience also, and of course also the time of the procedure now it's faster than in the past. And so we are now doing more cases than in the previous year. But as I told at the beginning, there is no the technique for me that fits for all. So referral centers should offer the best technique for that specific patient. So I still do glue, MOCA, foam, and whatever the specific case needs.
And how about the size of the vein? If you have a 23 millimeter uh, varicosity, sometimes the varicosities are huge. Some of those tributaries can be massive and they probably need to be treated. Is there a size limitation, or are you able to use some of the tumescent to try to reduce the size and spot weld or use different techniques?
That's another good question. I think that when you have a huge caliber of the vein, so a diameter that it's more than 15 millimeters, I think that laser it's the best way to go. And respect to all the other technique. Because you can do, of course, a good two-mission anesthesia to reduce the caliber. You can place your patient in Trendelenburg position to reduce the caliber, and but respect to other technique, of course, we can discuss about alligation stripping, but respect to the other ablative technique in when you have a huge caliber of the vein, I think that thermoablative still is the technique that could give you more chance to have a good occlusion rate at the follow-up. We are now basically not doing any more alligation and stripping, really selected cases. Because in this moment, I don't see any limitation of the ablative technique with respect to the past. We now have different type of fibers. For example, we're now having more firing zone. Well, not just with the double ring, we now have an infinite ring that it's a fiber with a firing zone of 5 millimeters with a lot of rings. So technology is really improving in this moment, and I think that it is possible to offer mini invasive technique in most of the patients. So the caliber, in my opinion, it's the best choice for a thermoablative technique respect to others.
Thank you so much for pushing the envelope and really helping explain some of these new technologies. It looks really exciting. I'm so happy that you're collecting the data. I'm really looking forward to your presentations with the upcoming data.
Thank you so much. Thank you so much also to give me this opportunity to share with you and all the reader of and the watcher of this podcast.